Hi, my name is Pamela Coons, Associate Professor of Medicine in the Division of Oncology at Yale School of Medicine and Yale Cancer Center. I'm excited to announce ASCO's new open access journal, JCO Oncology Advances. As the inaugural editor-in-chief, I hope to support JCO Oncology Advances to become the premier platform to bridge the gap between accessible scientific research and clinical care. Stay tuned for more information, including new article types, at ascopubs.org/JCO Oncology Advances. We look forward to seeing your submissions in spring of 2024.
This JCO podcast provides observations and commentary on the JCO article, Impact of FLT3 Internal Tandem Duplication, FLT3 ITD, on the outcome of related and unrelated hematopoietic transplantation for adult acute myeloid leukemia in first remission, a retrospective analysis on behalf of the Acute Leukemia Working Party of the EBMT by Brunette et al. My name is Charles Schiffer, and I am a professor of oncology and medicine and head of the Multidisciplinary Leukemia Lymphoma Group at the Karmanos Cancer Institute, Wayne State University School of Medicine in Detroit, Michigan. Recording Anything You Can't Do, I Can't Do Either, Transplantation for High-Risk AML. I would like to begin with a brief background to help place this unique and interesting paper in perspective. In recent years, it has become apparent that AML is a very heterogeneous disease with many subtypes definable by cytogenetics and more recently molecularly. These subtypes can have different clinical presentations and vary widely in outcome after treatment. In the past few years, there has been particular attention focused on the molecular characterization of the approximately 50% of AML patients with normal karyotypes, with the hope of explaining the considerable variation in outcomes seen in this group. A large number of mutations and patterns of gene overexpression have been identified, some of which are associated with better overall survival than others. It has also become clear that multiple abnormalities can be present in the same patient, such that there may literally be dozens of subtypes which may eventually be defined. Indeed, the pace of discovery has been so rapid, it almost seems like a Gene of the Month award may be in order. Perhaps the most attention has been focused on the FLT3 transmembrane tyrosine kinase receptor. Mutations in FLT3 can be detected in approximately 30% of patients with normal karyotypes, and multiple papers have demonstrated that the relapse rate with standard chemotherapy is much higher than in so-called FLT3 negative patients without such mutations. These mutations occur in two flavors. Most common are mutations in the transmembrane part of the receptor, characterized by internal tandem duplications of variable length. For the purpose of this podcast, internal tandem duplications will be referred to as ITDs. A point mutation can also occur in the D835 tyrosine kinase portion of the molecule. Both result in constitutive activation of the receptor, producing an ongoing proliferative signal. The situation is actually somewhat more complicated because there is controversy about whether patients harboring the point mutation actually have poorer prognosis, whether there may be different clinical effects of ITDs of different length, and whether the major negative impact occurs predominantly in patients with homozygous ITD mutations. A number of pharmacologic inhibitors of FLT3 signaling have been developed, including midostaurin, or PKC412, lestartinib, or CEP701, and AC220, amongst others. Initial trials with these agents, used alone, showed cytoreduction and sometimes rapid clearing of blasts, although with few remissions. A possible exception might be with AC220, which produced some complete responses in a phase 1 trial. A large phase 2 trial in relapsed patients is in progress. A randomized trial of chemotherapy with or without 701 in patients in first relapse failed to show improvements in either CR rate or overall survival. Randomized trials in newly diagnosed patients comparing standard chemotherapy with or without CEP701 or PKC412 are nearing completion of enrollment. Which brings us to the present paper from the EBMT. It has become standard practice to assess for FLT3 mutations at the time of diagnosis in patients with AML, leading to the practical clinical issue of what to offer as post-remission therapy to such individuals. The initial instinct, of course, is to consider allogeneic transplantation for patients who in general have a poor outcome with chemotherapy. There are no randomized trials specifically addressing the value of transplantation in FLT3 mutated AML. Two large retrospective analyses of patients have produced somewhat conflicting results, with a study from Germany suggesting benefit for FLT3 mutated patients who had a matched sibling donor, although not all were transplanted, while a similar donor-no donor analysis from the MRC in the United Kingdom failed to show an advantage for those with donors. Nonetheless, there has been a trend to offer transplantation to FLT3 positive patients. Indeed, in the EBMT paper, which was a retrospective multi-center comparison of transplant outcomes in a cohort of patients with normal karyotype AML in first remission, in whom FLT3 testing had been done, there were actually more FLT3 positive than FLT3 negative patients. The most important point from this analysis is that the relapse rate post-transplant was 30% in the FLT3 positive group compared to 16% in the FLT3 negative patients, with a correspondingly lower leukemia-free survival of 58 versus 71% respectively. Both differences were statistically significant, and the FLT3 status was an independent prognostic factor after multivariable analysis. Although it is conceivable that there were other unknown factors which could have influenced these results, they are consistent with other reports demonstrating higher relapse rate post-transplant in patients considered to be at high risk when chemotherapy is used alone. For example, recent publications have shown a very high relapse rate post-transplant in patients with so-called monosomal karyotypes who also have extraordinarily high relapse rates when chemotherapy is used alone. Thus, factors which confer resistance to chemotherapy also result in higher relapse rates post-transplant. Or, to paraphrase the old song, anything you can't do, I can't do either. Although the explanation could be as simple as the presence of a higher or more proliferative tumor burden, which the immunologic graft versus leukemia effect does not have the power or time to overcome, the mechanism is likely to be more complex. It is impossible to conclude from the EBMT data whether those patients who were transplanted, despite the higher relapse rate, did better than if they had been treated with chemotherapy alone. The answer to this question will not be forthcoming from prospective randomized trials. However, there have been a large number of trials, primarily conducted in Europe, which assigned all patients with AML in first CR to transplantation if a donor was available. A combined analysis of data from these trials comparing those FLT3 positive patients with or without donors, or those who did or did not receive transplant, is probably the best way to address this clinically very important question so that we can provide the best advice to our patients. It will also be a test of how well cooperative groups can actually cooperate and provide a model for assessing the role of transplantation in other molecularly defined subgroups. At this time, I believe it is quite reasonable to recommend transplantation to medically suitable patients with FLT3 ITDs or other characteristics predictive of a high rate of relapse with chemotherapy consolidation alone, because of the more potent allogeneic anti-leukemic effect and the fact that clinical trials have never shown inferior overall results using transplantation in this situation. However, when we discuss transplantation with these patients, the prospect of a higher relapse rate should be presented as well. Hopefully, the randomized trials with FLT3 inhibitors will be positive and change the parameters of this transplant decision. In the interim, the elusive goal of selectively increasing the graft versus leukemia effect without a concomitant increase in the ravages of graft versus host disease remains a critical challenge. This concludes this JCO podcast. Thank you for listening.
For more original research, editorials, and review articles, please visit us online at jco.org. This production is copyrighted to the American Society of Clinical Oncology. Thank you for listening.